My first question, of course, is what inspired you to become a spine neurosurgeon?
Yeah, it's a good question. My road to spine neurosurgery was a little bit different than some people. I actually started off as an electrical engineer,
Mm-hmm.
uh, and I was very interested in signal processing, and I liked math and so on. And then I did a master's in biomedical engineering where I got to work with some physicians, and I said, it'd be really cool if I could combine both engineering and medicine. And so that kind of got me to the thinking about doing medicine. And I actually went into neurosurgery wanting to do more functional neurosurgery because
Mm-hmm.
my PhD was in neurophysiology and so on. But as when I was in neurosurgery, I really enjoyed the aspects of spine surgery, the fact that you could see your results right away, and that there was a combination of both macrosurgery and microsurgery all in one, and you got to work basically from the bottom of the cranium all the way to the sacrum, and so I really enjoyed that.
How old were you when you decided to be a spine neurosurgeon after?
Um, Maybe I was pretty old, so I did my master's in biomedical engineering, and that would have been 24. And then I did my PhD. I started my residency at 31, and then probably my third year of residency. So it's maybe 33, 34 that aligned to decide to do spine surgery.
So it was a mature decision.
I hope so.
Can you describe a moment in your career that you're most proud of?
Um, you know, the things that makes me the most proud is really taking care of the patients. Education and writing papers and advancing knowledge is really, really great. But the most important thing and the thing that really sticks with you is helping patients, because patients come to you when they're very vulnerable.
Mm-hmm.
And if you can help them, that's a great feeling. And that's a feeling that, you can't really describe anywhere else. If you can use some of your research to help patients and to advance their treatment, that's always the best.
Yeah, that's true. A lot of people talking about mentorship and the best advices they ever receive from someone who is senior than them. In your case, what was the worst advice you ever received from anyone? It doesn't have to be from the mentors or seniors.
Yeah, so not everybody's going to believe in you,
Mm-hmm.
right? And I was told at one point that I would never be a neurosurgeon.
I was told
Uh,
to.
so, there's always going to be people that have doubts,
Mm-hmm.
and, you should not let what other people think affect what you can do. And if you work hard and you're dedicated and you put in the time, you will be able to reach your dreams. But not everybody will be a fan, and not everybody at all points of your life will
Mm-hmm.
be, encouraging. It's important to find out quickly who your fans are and who your mentors are, and the good mentors, and stay with them. And those people that aren't good mentors, to stay away from them.
That's a great advice. Um, what's the biggest misconception about spine surgery in general?
I think when people talk about back surgery or spine
Mm-hmm.
surgery, I think the biggest misconception is that no matter what, patients don't do well. Um, there definitely is a subset of patients that, for whatever reason, don't do as well as we'd like. But there's a vast majority of patients that do extremely well.
Mm-hmm. Um, your what's your personal style in the operating room?
So, the first thing I tell all patients is you should try to avoid surgery as long as
Mm-hmm.
you can, for two reasons. Number one is enough things can go wrong, you don't want to regret it. And number two is spine surgery, by definition, most of the time is due to a degenerative process. So if you take care of a degenerative process, that degeneration is still going to happen.
Mm-hmm.
And so you really want to make sure that if you're going to do surgery, you and the patient realize that it may not be their only surgery because degeneration happens. And unfortunately, sometimes our surgery can actually make that degeneration worse. So we may fix that one problem, but sometimes there are other problems that happen. And then if we have to go to the operating room, I always try to do the most minimally invasive spine surgery that I think is possible.
Mm-hmm.
Um, and in the operating room, I want to be safe, but also efficient. Having patients in the operating room for a long time is risky for them, just given just how long they're in the operating room.
Um, Now, in the world of spine surgery, what do you believe are the most exciting breakthrough happening right now?
I think the most exciting breakthroughs right now have to do with preoperative planning.
Mm-hmm.
So before we just used MRIs and we kind of just said, "Oh, I think this is what's going to happen." Uh, you know, Now we are able to look very, very carefully at all the nerve roots, all the discs, and so on, and we can do, very, very meticulous planning to make sure that the surgery is safe. I think that the use of artificial intelligence and
Mm-hmm.
machine learning, both preoperatively, intraoperatively, and postoperatively are going to be some of the things that we see in the future. I think robotics has a huge role. And some of the things that also is very exciting is we're doing now what's called awake spine surgery. So that means that we don't have to put the patient all the way to sleep. And we know
Mm-hmm.
that general anesthesia, especially for older folks, can be very debilitating. So now we're able to take that off the table as one of the things that makes us worried about spine surgery.
Um, Now, the number of awake endoscopic spine surgery have been increased. And how do you see the field evolving in the next 5 to 10 years? And what is your experience?
Yeah, I think that it's going to be, you're going to see more and more people doing it. Before it was very kind of only a few centers, but I think you're going to see more and more people doing it. And I think that there's two major advantages. Number one is that it avoids the problems with general anesthesia.
Mm-hmm.
But as we learned from our cranial, I trained in a very cranial heavy place at the Brigham, and I used to do a lot of awake craniotomies with Dr. Kioka. And so I'm very comfortable having the patient awake. And so one of the things that we can try to do then is to try to look at elephants, right? So
Mm-hmm.
as we take out tumors or as we take out discs, patients can tell us, and that's one of the coolest things in the operating room is if you take out a disc and the patient is awake and they tell you, "Oh, my leg pain is better." That's a really cool feeling.
Yeah, right away.
Yeah.
Talk about the preoperative planning for this procedure and the spine surgery in special. Um, how is your process of that of preoperative planning, taking consideration that there are a number of new technologies?
Yeah, so you want to look at not just the spine, but actually the whole
Mm-hmm.
human being. And so we've in our system we've found eight reversible things that patients can actually help in, right? So
You're
if they're overweight, if their diabetes is not under control, if they're smoking, if their hypertension is not under control, those are all things that will increase the risk of having something bad happen in the operating room or outside the operating room. So we always try to minimize that. So we always try to work with the patient to kind of have them really ready for surgery. So that's, kind of as a big picture. And in terms of the spine, we're using more and more technologies such as CT spec to kind of figure out
mm-hmm.
what the pain generators are. We also rely heavily on our physiatry folks to do what we call diagnostic and therapeutic injections. So if you get an injection in a certain area and the patient does well, that's diagnostic. And if they do well
Mm-hmm.
for a long time, then that can be therapeutic and maybe they can avoid surgery. And then we're using very new technology to map out, all the nerves and so on to figure out what the best trajectory is into the spine.
Of course, we can totally avoid cognitive biases. What can we do to minimize them?
biases from the surgeon, or
In general, like a surgeon, we can make a lot of mistakes and we can have cognitive biases. How can we avoid that?
yeah, I think that that's a challenge. I think that there is going to be a role for artificial intelligence
Mm-hmm.
to kind of, I hope, help kind of push us and see things that we don't normally see. There's so much that we don't know about spine surgery,
Mm-hmm.
and I think that it may take, types of analysis that we're not used to really figure out, I think there is a problem in that there, if you look at 70% of adults will have back pain at some point, right?
Mm-hmm.
We definitely should not be operating on 70% of the population. There's only going to be a very small population that does well with surgery. So figuring out who those people are is going to be really important.
Um, how how do you think we can identify those patients who will benefit from the surgery?
Yeah, so I think that's going to take some effort. We're working on some machine learning algorithms. So
Mm-hmm.
what we want to do is take all the patients with back pain, not just the ones that had surgery, but people that have back pain, look at what different modalities they have: physical therapy, chiropractic care, surgery, injections, and then run them through an algorithm. Actually, we're doing a study like that right now. Run them
Mm-hmm.
through an algorithm and figure out, hey, can we, based on these patients' characteristics, and some of them we are not the characteristics that we may even think about, right? They could
Mm-hmm.
be, how much degeneration they have in their fatty cells around their back, not
Mm-hmm.
in the spine. That kind of will tell us, hey, this patient will do well with surgery. This patient will be better served losing weight or something else.
So, you're mentoring and training new generation of neurosurgeons, and it's not an easy task. Sometimes when you delegate those tasks to them, or even under your supervision, they may perform poorly. How do you overcome this, and how can you objectively assess their capabilities?
Yeah, that's a really challenging thing, right? Because
Yeah.
um, you want to be a supportive mentor,
Mm-hmm.
and then maybe somebody just doesn't make the grade. That's difficult because we started off the conversation saying that you don't want to listen to people that say no, you can't do it.
Mm-hmm.
But then are there some people that just can't do it? I don't know. I think that's challenging. I always believe in giving people, second and third and fourth chances.
Mm-hmm.
But I don't think everybody, even wants to be a neurosurgeon,
Mm-hmm.
because it is a very intense field, both in the operating room and outside the operating room. And there's a lot of pressures, right? So
Mm-hmm.
you have to know how to deal with pressure and deal with it in an appropriate manner.
There is a pressure. You have to treat the patient, and at the same time, you have to mentor and train a new generation and pass the knowledge to them. In your
And do
experience,
research.
yeah. Link after spine surgery is physical versus psychological. Can a strong mind overcome physical limitation, or are the physical barriers invincible without medical intervention?
That's a really good question. I think that we really haven't unlocked, the mind's ability.
Mm-hmm.
And I think that I have patients that surprise me every day with their tenacity. And I think that makes a huge, huge, huge difference. Really living in the moment really is important. So, I think that physical things are important, but I think psychological and social factors play a huge role.
Mm-hmm.
And I see that every day.
We talk about artificial intelligence, and with the increasing role of technology in surgery and the patient care, how do you ensure that the human element remains central? How we can ensure that the human element remains central to the practice of medicine? Do you think will compassion be programmed into the machine somehow with time in 10, 20 years?
Maybe, I think the major problem that we all have is that there's only 24 hours in the day. And so sometimes it's hard to give the time and to give the compassion that you want. And so
Mm-hmm.
maybe in the future there will be, things to help, with some of that. It's really important to distinguish between important activities and not so important activities,
Mm-hmm.
right? So I definitely think that there's some activities that can be delegated to artificial intelligence or machines and so on, and some of them that you simply can't. Sitting beside a patient when they're going through a hard time, or if there's a complication, those things can't be delegated to artificial intelligence.
That is all. Thank you so much. You went like faster than I thought. So
Okay, great.
yeah, if
Uh,
there is anything you would like to say or share with a broader audience.
Yeah, for those people that are thinking about neurosurgery or spine surgery, it's a great field.
Mm-hmm.
You get to really help patients, but it is a demanding field, so you have to be ready to do that. And I read somewhere, pressures and demand is a great responsibility, and it's something really to that you can actually feel proud of. That people have pressure
Mm-hmm.
on you, have demands on you. For the patients that are out there, always try to look for a compassionate physician.
Mm-hmm.
That's really important. And to all the young generation, we're looking to you, to really push the field. Because if we're doing the same thing we're doing now 10 years ago, then we've all failed. We really need to
Yeah.
take it up to the next level and look at, new technologies and new ways to treat patients.